Okay, it's 9:03 and I'll get started. Thank you for joining today's webinar. Today, we're going to learn about the COVID-19 interviews that were fielded by the International Network of the Health and Retirement Studies in response to the global pandemic and the brand new harmonized COVID datasets, and go through a sample analysis focusing on this new data from the Health and Retirement Study in the United States and the Survey of Health, Aging, and Retirement in Europe. I'm Cody Young, and I'm a programmer from the Gateway to Global Aging Data team at the University of Southern California. We would like this webinar to be interactive, so if you have any questions or comments during the webinar, please feel free to use the chat box. This presentation and the State of Do file used in today's webinar will be made available for download on our website. First, I will provide an introduction to the COVID-19 interviews and to some of the variables in our harmonized COVID datasets, along with some next steps for these datasets. Then, Hunter Green from the Gateway to Global Aging Data team at USC will walk us through an analysis using the Harmonized HRS COVID and the Harmonized Share COVID. I'll first provide a brief background on the International Network of the HRS Studies, otherwise known as the HRS-INS. These are population representative of older adults, typically folks who are 45 years of age and older. They're longitudinal studies because individuals are followed over time. Surveys are typically fielded every 2 to 3 years, depending on the study, asking the same kinds of questions in order to see changes or trajectories among individuals. They're multidisciplinary because these are studies that incorporate a lot of different research domains that affect people's lives as they transition into retirement and to the end of life. These studies also have coordinated survey instruments. A similar question is asked similarly across different countries or in different contexts for comparability. Many of these studies also have enhanced economic data to provide good measurements of income, assets, and wealth, for example. Additionally, these surveys not only provide self-reported data, but also measurements of biomarkers such as people's height and weight. Some studies also collect saliva or blood samples. Best of all, these data are all free and publicly available for anyone to utilize after registering. When the COVID-19 pandemic began, no one could have predicted the dramatic effect it would have on the day-to-day lives of the world's inhabitants. Because the health and retirement studies have been fielded around the world longitudinally in over 40 countries, they are uniquely primed to collect information on how the COVID-19 pandemic has impacted older individuals around the world. Providing a brief background on the health and retirement studies around the world, the HRS first began in the United States in 1992. The next group of studies were conducted in the early to mid-2000s, and some were started more recently, having only conducted a single wave of interviews thus far. In total, these studies have been fielded in over 40 countries. This slide here lists some of the countries, and countries are listed in the order they were added to the network of the HRS studies. So the second study to be conducted after the US was Mexico, followed by England. Some studies added COVID-19 specific questions to their core self-completion surveys, while others conducted entirely separate COVID-19 interviews. Most studies have collected data at multiple time points between 2020 and 2022. COVID-19 questions or interviews have been fielded in the bolded countries on this slide, as well as in Chile. The HRS in the United States, MHAS in Mexico, ELSA in England, Share in over 20 European countries and Israel, Tilda in Ireland, Halsey in South Africa, Charles in China, Lassie in India, Haggis in Scotland, Nicola in Northern Ireland, Mars in Malaysia, Elsie in Brazil, and SPS in Chile have all fielded COVID-19 interviews or included COVID-19 related questions. In the COVID interviews, we've identified 10 core content areas in which questions were fielded to respondents. This includes demographic-related questions about age, geographic region, and whether respondents are currently living in nursing homes. The COVID-19 section includes questions related to diagnoses, experience of symptoms, COVID-related hospitalizations and deaths. Mitigation behaviors contain questions pertaining to the respondents' behaviors, such as leaving home, wearing face masks, using hand sanitizer, and social distancing, as well as the information sources that were utilized to receive COVID-19 related news during the pandemic. The health section looks at changes in health and health behaviors, and the healthcare section contains information related to delayed medical care. The economic section looks into whether respondents or their households have experienced changes in income or spending, missed paying bills, experienced food insecurity, or received financial support from the government. Employment questions look into whether respondents have changed their jobs, hours, and locations, and whether their jobs have gotten riskier since the pandemic. Caregiving questions were fielded to relay information on whether respondents, their spouses, or their households have received or provided care or help with chores, and the relationships care or help was provided from or to. The family, social contact, and activities section includes variables pertaining to the respondent's communication with others and changes in their relationships or activities. Lastly, the psychosocial section includes questions related to loneliness, depression, anxiety, spousal support, and discrimination. This slide shows the collection periods for the COVID-19 interviews that the Gateway is currently working on harmonizing, which includes the HRS, ELSA, and SHARE. Because some studies fielded separate COVID interviews that were not part of their regular core interviews, we refer to regular core interviews as waves and to COVID interviews as rounds to make it easier to distinguish. The first round of COVID-19 questions were surveyed in the HRS as part of their regular core interview from March 2020 to June 2021. Round 2, which was a mail survey, was fielded from May 2021 to July 2022. Round 1 of ELSA COVID was fielded from June to July of 2020, and Round 2 was fielded from November to December of the same year. Round 1 of Share COVID was fielded from June 2020 to September 2020, and Round 2 was fielded a year later, from June to August of 2021. Please note that our first releases of the Harmonized HRS COVID and Harmonized Share COVID will only include Round 1 data, but we plan to incorporate Round 2 information in future releases. Because the breadth of studies collecting such broad data in so many different countries can appear overwhelming, the Gateway to Global Aging Data initiative was started 15 years ago as a tool for researchers to understand the information collected in these surveys and how to obtain access to these data. We also realized that it takes a lot of work to understand just one study, and even more work to understand these studies in relation to each other. To encourage and facilitate more exciting research done comparatively across countries, the Gateway was built to be one central platform for researchers to tap into this network of HRS studies. The Gateway provides an overview of the HRS family of studies. This includes an overview of the study itself, the survey questionnaires that were fielded, flowcharts that illustrate questionnaire skip patterns, and a search function that can be used to look up specific keywords or topics. We've built cross-study concordance tables of specific research survey topics and created in-depth documentations for cross-study comparability. We also provide survey statistics and contextual data, which are shown in interactive graphs and tables. Our latest initiative is the Policy Explorer, which seeks to understand the regulatory and policy environment for the individual at different points in the survey. For example, pension policies have changed drastically in the past 20 years. So this Policy Explorer provides information on what specific pension policy was in place at a specific time. We are also actively working on adding long-term care and education policies to the Explorer. We have a publication search for published papers that have utilized the HRS family of surveys in their analyses. And lastly, we also provide harmonized data, which are research-ready data sets that we have developed for a subset of information from each survey with some of the most commonly used variables. The Gateway includes a number of different features designed to help familiarize researchers with the COVID-19 interviews. We have a separate website domain that is fully focused on COVID-19 and can be accessed through covid.g2aging.org. Our website includes survey metadata, which is essentially a library of all survey questionnaires, concordance tables, which are coming soon, graphs and tables, global policies, and our harmonized data and codebooks with more set to be released soon. There are two ways to access our COVID-19 website. You may type in covid.g2aging.org, or if you are already on our main g2aging.org website, you can access the COVID-19 webpage by clicking on our logo and selecting COVID. The landing page provides an overview of our Gateway to Global Aging COVID Data Initiative, news, and a highlight of some upcoming features. We will be adding additional graphs, tables, and contextual data soon. Our Surveys at a Glance webpage provides a quick summary of the studies that have released information about their COVID-19 interviews, such as their questionnaires or survey instruments. As you can see, we have provided metadata for the HRS, ELSA, SHARE, Tilda, Halsey, Nicola, and La Ciudad. Each link brings you to the metadata for that study's survey instrument. On the far right column, we've also provided metadata for some of the harmonized COVID datasets that we're currently working on, such as the Harmonized Share COVID. If we click on the link for Share's COVID-19 questionnaire for telephone interviews, we're brought to a table that lists out each section in the round 1 instrument. Clicking on the section will lead you to a table of the question's description and its label. For example, if we click on the quality of healthcare link, we're brought to a table of healthcare-related questions that were asked in round 1 of Share COVID, such as whether the respondent forewent medical treatment and the types of medical treatment that were foregone. The left column shows labels, which are the variables' names, and the right column lists the questions that were asked to respondents. Clicking on a variable's name will also bring up the answer choices for each question, such as yes or no. Please be sure to check the Gateway's COVID website often, as we're always adding new features as we work on harmonizing these data for our users. COVID-19 interviews were conducted in order to obtain more immediate information on the impact of the global pandemic on the respondent's life and on their household. Because this pandemic spread so quickly, each study rapidly developed questionnaires to take advantage of this historic time. However, this meant that the questionnaires were developed quite differently for each study. Here at the Gateway, we've created harmonized COVID datasets to provide comparable research-ready variables. Harmonized variables contain a subset of the original survey variables and are defined as similarly as possible across all harmonized datasets. To differentiate between the core surveys that are fielded every 2 to 3 years and the COVID-19 surveys that were fielded in this pandemic, we call each fielded COVID-19 study rounds. Each dataset combines all available COVID-19 rounds, and each individual is counted as one record. An intuitive variable naming convention is used across all harmonized data. For example, the variable R1-CoV test indicates whether the respondent has had a positive coronavirus test result as of round 1. Study-specific variable names are also employed to indicate slight differences. For example, the variable R1-CMaskF_S indicates the frequency the respondent wore a face mask in round 1 of Share COVID. Because Share COVID utilizes a different response scale, an _S has been added to the end of the variable to indicate this difference. Spouse versions of most variables are also created. The variable S1C work indicates whether the respondent's spouse is currently working as of round 1. All variables have been built to account for any survey skip pattern, and each dataset is accompanied with a harmonized codebook, which provides detailed information on how the harmonized variables were created and summary statistics for most variables. The data creation code for the Harmonized Share COVID, which includes round 1 information, is now available on our website. We've completed programming the Harmonized HRS COVID, which includes round 1 data, and it is currently being reviewed by the HRS team. The Harmonized ELSA COVID, which includes both rounds 1 and 2, is also currently in progress and we expect to complete this data file soon. We have plans to harmonize additional COVID-19 interviews from Tilda, Elsie, SPS, Charles, MHAS, and Mars. We will also work on incorporating round 2 information into the next releases of the Harmonized HRS COVID and Harmonized Share COVID. We are happy to announce that the data creation code to create the data for the Harmonized Share COVID is now available for download. To access this, please make sure you register as a user on our Gateway website. You will only need to register once, as the same username and password combination can be used across all g2aging.org websites. Once you are logged in, you can head to the download page where we have provided links for where to go to download the Share COVID data, as well as the data creation code and instructions on how to create the Harmonized Share COVID datasets. We hope to release the Harmonized HRS COVID and Harmonized ELSA COVID datasets to our users in the near future. We will always announce our new dataset releases, so please make sure to opt in to receive announcements when you sign up. If you're already a Gateway user, you're able to log in and adjust your preferences for this as well. Now, I will turn this over to Hunter, who will walk us through a sample analysis using the Harmonized HRS COVID and the Harmonized Share COVID.
Hello, my name is Hunter Green, and I'm a programmer with the Gateway to Global Aging Data. Today, we will be walking through a quick example analysis using the Harmonized HRS COVID and Harmonized Share COVID datasets that Cody mentioned. So we'll go ahead and pick a research question that we can use to get some experience using these new Harmonized COVID datasets. One of the many negative consequences of the COVID-19 pandemic, especially early on, was widespread healthcare delays. While delaying healthcare has the ability to hurt anyone, it may be more harmful to people who have chronic diseases like hypertension or high blood pressure that require regular clinical management. Thus, we may expect to see less delayed care among people with hypertension. During the remainder of this webinar, we'll seek to determine whether the prevalence of delaying medical care differs by country, and in addition, we'll investigate if having hypertension makes someone more or less likely to delay medical care. So to get started with our analysis, we'll first have to download the RAND HRS and Harmonized HRS COVID datasets and create the Harmonized Share and Harmonized Share COVID datasets. Then we'll identify the variables we need, create a pooled dataset with observations from both HRS and Share, create additional variables, and start analyzing whether the prevalence of delayed medical care differs by country. The RAND HRS dataset and codebook can be downloaded from the RAND HRS products page on the HRS website. In the image on the right, I have circled the dataset we will be using, which is the RAND HRS longitudinal file 2018, which is distributed in Stata, SAS, and SPSS formats. I will be using Stata for our analysis today. As Cody mentioned earlier, the Harmonized HRS COVID data file is not currently available for download. However, when it becomes available, the data and codebook will be available to download from the contributed products page of the HRS website. The image on the right shows the expected location on the HRS website where the Harmonized HRS COVID will be stored. In addition, this data file will also be distributed in Stata, SAS, and SPSS formats. The Harmonized Share and Harmonized Share COVID datasets cannot be directly downloaded from either the Share website or the Gateway. As such, creating these datasets requires a couple of extra steps, but we've done our best to make this process as seamless as possible. The first step in creating the Harmonized Share is to download the data creation code and codebook from the Gateway to Global Aging Data downloads page. Next, users are required to download the state of data for waves 1 through 8, the longitudinal weights, and the all waves cover screen from the share website. The final step is to adjust lines 14 to 24 of the Stata creation code and run the code using Stata. Unfortunately, for some of you who use a different statistical package, you will need access to a copy of Stata SE or Stata MP in order to create this dataset. But once it's created, you can use a program like stat transfer to convert the Stata dataset into a different statistical package, and you never have to use Stata again. When you download the Harmonized Share Stata creation code from the gateway, it will look like the picture on the left, with double bars on either side of the folder locations, indicating that you will need to personalize these for your particular computing environment. This setup assumes that you've downloaded and saved the share data in a similar fashion to the picture on the top right. Here I have separate folders for the cover screen, weights, each wave 1 to 8, and a separate folder to save the data set we create. And then all of these are saved in a folder on the desktop of the computer called share. All you need to do is provide the locations of these folders on your computer to lines 14 to 24, save the changes to the code, and run this code in Stata. The first step to creating the harmonized share COVID dataset is to create the harmonized share data, which we had just gone over. Next, users must download the harmonized share COVID Stata creation code and codebook from the Gateway to Global Aging COVID data downloads page, which Cody just showed. Users are then required to download the Stata data for Wave 8 COVID-19 Survey 1 from the share website. The final step is to adjust lines 12 to 14 of the Stata creation code and run using Stata. I'll skip over this slide because the process to create the harmonized share COVID and harmonized share datasets are so similar, but I'll leave it in the slide deck if anyone would like to refer to it at a later time. Next, we'll move on to identifying the variables we need for our particular research question involving delaying medical care. We'll mainly be using data from the Harmonized HRS COVID and Harmonized Share COVID datasets. In addition, we'll also be bringing in a couple variables from the most recent HRS and Share core interviews before the pandemic. This is because while the core interviews ask respondents if they have ever been diagnosed with hypertension or high blood pressure, the COVID interviews only ask if the respondent has been diagnosed with hypertension since the last core interview. We'll start, though, with the variables that we are using from the Harmonized HRS COVID dataset. First, it's always appropriate to include the respondent's ID, which in HRS is called HHIDPN. Then we'll need the indicator for whether the respondent delayed any medical care during the pandemic. This is called R1CDLY care. Also, when we run a regression later, we'll include age and gender as covariates. The age and gender variables are R1C age Y and RA gender, respectively. Finally, we'll include an indicator of whether the respondent participated in the COVID Round 1 interview, called INCR1, and indicators for the year and month that the respondent was interviewed, which are R1CIWY and R1CIWM, respectively. We can use the respondent's ID, which is HHIDPN, to merge in information from the RAND HRS about the last core interview before the pandemic, which is Wave 14, which was fielded between April 2018 and May 2019. We'll bring in two variables from the RAND HRS, an indicator for whether the respondent participated in Wave 14, and whether the respondent was ever diagnosed with hypertension prior to the Wave 14 interview. We'll be using similar variables from the harmonized share and harmonized share COVID. The only differences are that in share, merge ID is the name of the respondent of the individual identifier instead of HHIDPN. Also, we're bringing in an extra variable called country from the harmonized share COVID, as that is not available in the harmonized HRS COVID because the only country that is surveyed in HRS is the United States. Also, for share wave 8, or also for share, wave 8 was the last core interview before the pandemic, not wave 14 like HRS. And now I'll open Stata, and we can work on creating our data set. So if you're new to Stata, many of the commands will be similar to those seen in other statistical packages like SAS, SPSS, or R, so it shouldn't be too difficult to follow along. I'll open the do file editor within Stata and open the program for today's analysis called Intro COVID. Let me find it first. Intro COVID webinar, November 2022. So we can open that. For you to run this program, you'll need to edit line 10 of the program that we released on our website. We'll click this icon, execute, to run the do file. And we have included the pause option. And so during the analysis today, the program will pause at different points and we can review the results. So we can execute the do file by clicking on the icon at the top right. We can go back to Stata. When we switch to the output screen, Stata has run into the first pause. And we are ready to continue when we type the letter Q and enter the program that will run until the next pause. I'll bring the commands on the slides so it's easier to see. Then we'll switch back to Stata to look at the outputs. Okay. The first thing we need to do is read in our observations and variables from the harmonized HRS COVID. Stata works by building a data set in its memory, so we employ the command use to bring in the variables we identified earlier into Stata's memory using the harmonized HRS COVID. Then we will use the command merge and the variable HHIDPN, which is the respondent's unique identifier, to combine the harmonized HRS COVID dataset we've just built with the RAND HRS longitudinal file 2018. We'll then limit at this step, where my mouse is, we'll limit our analysis to only include respondents who participated in both the COVID-19 survey and the most recent core interview before the pandemic. And we'll do that using the command keep. Then we'll save this data set as a temporary file so we can prepare the share data. Like the last step, we first bring the harmonized share COVID variables that we identified into Stata's memory using the command use. Next, we combine the harmonized share COVID and harmonized share datasets using the merge command with the merge ID variable. Then, like last time, we'll limit our analysis to only include respondents who participated in the COVID-19 survey and the most recent core interview before the pandemic. Finally, we'll also save this dataset to a temporary file so we can append the share and HRS datasets together. We're now ready to combine the prepared HRS and share datasets using the command append. Using the generate option, we can create a new variable called study so we can more easily keep track of which respondents are from HRS and which are from share. Because we listed the HRS dataset before the share dataset when appending, this variable is assigned a value of 1 for HRS participants and 2 for share participants. We'll quickly label these values so we don't forget who is assigned 1 and who is assigned 2. We'll do that using defining this label called study lab. You may have noticed in Cody's graphs earlier that earlier in the webinar, that while round 1 of Share COVID was fielded between May and September 2020, round 1 of HRS COVID was fielded between March 2020 and May 2021. I know that we've already provided a lot of information in the webinar already, so let's take a look at this in Stata. We can do this by tabulating the respondents' year and month of interview by the study. When we go back to Stata, we can see that for HRS, which remember was study number 1, we see that the respondents were interviewed in 2020. They were interviewed between March and December. And in 2021, they were interviewed between January and May. For Share, respondents were interviewed between May and September 2020. To look at this a little easier, we can go back to the PowerPoint. And here's a graph when these interviews were fielded by country. The red lines in this graph correspond to the timing of the latest core interview before the pandemic, and the blue lines correspond to the COVID-19 survey. As you can see, in the Share countries, which is every country here besides the United States, their last core interview ended in early 2020, while the United States finished their latest core interview in early 2019. Also, from the bottom of the graph, you can see Portugal, which is the only Share country to participate in the COVID-19 survey, but not the previous wave. And while respondents from Portugal did not participate in wave 8 of Share, they did participate in wave 7. Because round 1 of the HRS was in the field much longer than Share, let's limit our analysis to only HRS respondents who were interviewed in the same time period as the Share respondents. We can accomplish this by using the command keep and retaining all participants who were interviewed between May and September of 2020. We'll also limit our analysis to only looking at the United States from HRS and 3 countries from Share: Germany, Italy, and France. To do that, we'll add the United States to the Share country variable, relabeling that variable, and use the command keep and list the country identifiers for those 4 countries. We'll then perform a tabulation to make sure we selected the countries correctly. So we can click Q. And we can see that before we added HRS, we can see that no Share country had the identifier of number 10, of lower than number 11 or higher than number 63. So just for ease, we'll assign the HRS, people from HRS, the number of 10 as the country identifier. Then once we limit the respondents to only people in the United States, Germany, Italy, and France, we can tabulate this again and see that yes, we are left with only respondents from those 4 countries. Switching back to Stata, we can see that we only have 4 countries in our data set. We are now at the last step before our analysis, creating the hypertension variable. Creating the hypertension variable that combines the latest responses before the COVID-19 pandemic from HRS and Share. For HRS, as a reminder, this variable was R14 HIBPE, or if the respondent was ever diagnosed with high blood pressure or hypertension. And for Share, the latest interview before the pandemic was wave 8. So it's R8 HIBPE. And we'll define a label and just label people who have 1, they have ever been diagnosed, and 0, they have never been diagnosed. So finally, we can get to our analysis now that our data set is ready, and we can take a look at the proportion of respondents reporting delayed medical care by country. So we can see the stated command for this is proportion R1C DLY care, or if the respondent reported delaying care during the COVID-19 pandemic by country. Switch back to Stata. And here we can see that about 30% of Americans reported delaying care in the early months of the pandemic. About 33% of Germans reported delaying care, 34% of Italians, and 44% of French people. So if we move back to PowerPoint, we can see this a little more clearly using these bar graphs, which can really make the confidence intervals stand out. And you can see that the confidence intervals do not overlap for France, showing that France, many more people in France reported delaying care than the United States, Germany, or Italy. The next step of our analysis is to look at the prevalence of delaying medical care by hypertension status. So we can use a similar command as before, looking at the proportion of people who reported delaying care. Now we're looking at by both country and whether the respondent reported having diabetes before the pandemic, in the core interview before the pandemic. So we can go back to Stata, press Q. And you could see this output that Stata provides. It's a little difficult to see. So we can go back and instead see another graphical representation of this that shows how delaying care differs by hypertension status in these different countries. So you can see between people who did and did not have hypertension, this doesn't really differ in the United States. A few more people who have hypertension reported delaying care than the United States, but this was not statistically significant. Same thing with Italy, or same thing with France. A few more people, a higher proportion of people reported delaying care, but not statistically significant over people without hypertension. But Italy, we see that the confidence intervals do not overlap. So that means that there is a significant difference between people in Italy who report, people who have higher hypertension reporting delaying care more than people who don't have hypertension. So the final step in our analysis will be to perform a logistic regression using delayed care as the dependent variable and hypertension status, age, and gender as our independent variables. In this model, we will be interacting hypertension status and country, which will allow us to determine whether we are seeing the same pattern across countries or if the relationship is country specific. To do this in Stata, we will use the command logistic. The first variable that we will specify is our delayed care variable, R1C DLY care. The second two variables we specify are the indicators for if the respondent reported having hypertension before the pandemic and the country variable. We added a I dot before each variable to indicate that they are categorical. We also added two number signs, or if you will, hashtags, between the variables to indicate that's to Stata that we would like to calculate the main effects for hypertension status and country separately and the interaction of both. The final two variables that we specify are the respondent's age, R1C age Y, and gender, RA gender. Like we did before with the hypertension and country variables, we added an I dot before RA gender to specify that this is a categorical variable. We also added a C dot before the age variable to indicate that it is continuous. When we run this model, we find that looking across all countries and controlling for age and gender, hypertension is not associated with delaying care. Holding over other covariates constant, only France has a statistically significantly higher odds of delaying medical care than the United States. For the interaction between the countries and hypertension status, Germany and Italy appear to both have higher odds of delaying care if they have hypertension than people in the United States, while in France, the association is not significant. In addition, both increasing age is associated with the slightly lower odds of delaying medical care, and being female is associated with increased odds of delaying medical care. Overall, it appears that having hypertension is associated with delaying medical care in Germany and Italy, which may be a result that might seem counterintuitive because diseases like hypertension require clinical management. However, this could also be due to the status of the pandemic at the time of the interviews, like how many cases were going on in the country, and the effectiveness of the public health messaging, telling people if they have chronic conditions, they may be more likely to contract COVID or have severe outcomes. But obviously, there are much more things that we could do with these analyses using these exciting new data sets, and we're always happy to help you with your questions. And that brings us to the end of our analysis and our introduction to the Harmonized COVID data webinar. And we hope that this was helpful for you. You can learn more about the HRS, SHARE, and the Harmonized COVID data sets and other health and retirement studies at the Gateway to Global Aging data website, g2aging.org, and the Gateway to Global Aging COVID data website, covid.g2aging.org. You can also reach out to our team using the Gateway Help Desk by emailing help@g2aging.org. The recording, slides, and data code used in this webinar will be available on the Gateway webinars page in the next 24 hours. You can also find many previous Gateway webinars covering other studies, other types of data, cross-country analyses, and longitudinal analyses. Finally, I would like to encourage you to visit the Gateway blog, which covers a variety of topics of interest to researchers conducting research on aging populations. Now that the webinar has concluded, Cody and I will be staying around for a little while to answer questions. But if you're leaving us now, thanks for attending and have a great rest of your day.